Okay, so Dr. Belziki, we're back because I do have a question. I noticed that you used two impressions for the case. Can you tell us why that was important for you to do and why did you do it? And in light of what we just published on Oasis from Dr. Nate Lawson about diagnosing failed impressions, is that what you usually do in your practice?
The short answer is yes. Um, uh, my whole series of posts on Oasis, the whole philosophy of care that I've tried to demonstrate is sweating the details. Dentistry's hard, dentistry's difficult. It's even getting more hard and difficult now, having to wear this stuff, having to wear our masks and all the rest of it. By the time you have all this on, trying to pick up every detail, trying to prepare teeth, it's getting harder and harder. But that doesn't mean that we can't do it. It's just made the game a bit more difficult. So recognizing I'm fallible, on these cases where there are multiple abutments, you can miss something somewhere. Now, I can only address impressions such as I'm taking them. I can't talk about digital. I don't know the world of digital, but I know that my lab technician tells me that if you can't take a good regular impression, chances are you're not going to take a good digital one either. And I think another post was done 2 weeks ago where somebody addressed the difficulties in digital impression taking. So you have to go back to that person to address that phase. But an error when there's a large case and I'm going from here to here on multiple abutments, I want to give somebody a restoration that will withstand the test of time. And that means eliminating all the small errors. I don't want to pass those down the line. So trying to prepare teeth as correctly and as atraumatically and as judiciously as possible. Once I've done that, and I spend a lot of time on tooth preparation, I've got to get all that information here on a stone model. Digitally, again, that has to be addressed by somebody else. But however you do this, you have to give the lab all the information on what you've done so they can make a restoration that fits properly, which is why I do metal framework try-in, solder indexing to make sure I've eliminated everything that's within my power, because there's a lot that's beyond my control, but whatever is in my control, I try to eliminate all of those errors in order to give the patient a restoration that I can be proud of and that I know will stand the test of time. So going back here, yeah, that's where the margin is. I carved it. I kind of know what it looks like. So if I wanted to, I could have taken a little bit of impression material on an end of a probe and just laid it in there so that when the lab technician, when this gets poured up, they can see the model jump out at them. Nate Lawson went into some detail. He was asked, well, how do you diagnose? What do you go through to assess whether an impression is defect-free or not? It's not all that difficult. I mean, it's something we all should know. You want, obviously, all of your prepared tooth structure and the margin and a little bit beyond. You have to see a little bit beyond the margin. So it's defined for the lab technician. This case, in this one here, same impression. I had a void. Now, if the void was up here, I wouldn't stress it that much because at least the margin would have been captured. But if it's right at the margin, exactly how big is a bacteria? How big of a gap would I have ended up with? And ultimately a failure, whether in the short term or the long term, I don't care. If I can correct it, if it's within my power, would I not want to do this? Would I not want a dentist working on me to do that for me? So that's why to custom trays are ready as a just in case. The material I use is this one from Pentron. It's not any better, any worse in its physical characteristics than the other ones. A universal that goes into the custom tray and a light body that's syringed around each tooth. But I just find the color easy on my eyes to be able to detect those defects. I saw some that were bright yellow, and just those colors, for me, for my eye, were not conducive to picking up defects. So I use this material. By contrast, I had an impression and a model sent to me to be critiqued. Here's a stock tray. I've made much about using custom trays because a custom tray will fit an arch more intimately, more correctly. And here you can see that this flange is already bumping up against structures on the contralateral side of where the teeth were prepared. You can see it right here. But even on the side where there was tooth preparation, there was a compression up against tissue. So that can distort whatever material you have here. There are two defects that are present, one here and one here. As I mentioned, and as Nate Lawson had mentioned, you want the margin and a little bit beyond. Here, I can just kind of make out where the shoulder is, but I can't see that little bit of excess flash beyond. So as diligently as I could, I've tried to outline where I think the margin is. And I know that right there is the end of prepared tooth structure. And I have a void right here. And there's another one in this area. The margin, as best as I can make out, and there's the extent of prepared tooth structure in the impression. Yet, when one goes to the study model, well, there's a nice shoulder here, and there's one here. Again, distal of the molar, and that's the accompanying impression. Well, how did this get here? Because it's not there. So in my mind, a lab technician or somebody had to fudge it. They had to fake it. What would it look like extrapolating from what information do I have here? So all of this is guesswork, and it's probably the margin or the shoulder is probably more apical and out a little bit so that it won't interfere with the majority of the casting sitting on what could be picked up. Same thing on the bicuspid. The shoulder's on the stone model, the shoulder is not in the impression. It's not that hard to know whether you have a defect or not. So we can all have a bad day, and this is my impression. I took this of somebody, and this was just cemented in, this crown was cemented in a week or so ago. And took the impression, I thought it was okay, sent it off to the lab. The lab and I have an arrangement. They have to supply me with the perfect fitting crown, but I have to supply them with the best impression I can, or we call each other. And he phoned me and he said, you've got 3 little pulls here. Do you want us to just knock it off? I said, send me the model, let me look at it. If anybody has to guess, I'll guess. So here you can see where the defects are. So once I got it in my hand, I thought, I don't know, I carved it and I can't fake it properly. I don't have confidence in that. So I phoned up the patient and I said, you've got to come in. We've got a problem. The impression wasn't as good as it could be. I've got to take another one. Now, you might think that a patient would get upset. Oh, you know, I've got to, all the way from Mississauga, I have to drive back to Toronto. But in fact, it's the exact opposite. A patient will appreciate the fact that you follow up on something that could be done better. They understand that. Particularly, this patient is an engineer. So on that type of person, it's even better. So look, I can do better. We need another impression. Sorry, I have to get you frozen, and we just have to do it again. And we did. So here's the second impression. compared to the first one. It's very clean all through here because I want to deliver, as I said, the best fitting crown, the best fitting seal I can muster. And it's important in this case because that's an amalgam plug. There's the lingual surface, but that's an amalgam plug because I had to do endodontic therapy for this tooth prior to making the crown to a pre-existing crown. And it was a difficult endo. I had a mesiolingual root and I had a mesial buccal and the distal were webbed together. I had to have her back twice to make sure that everything was asymptomatic before completing because it was an odd anatomy. So my endodontic colleague, Dr. Andrew Moncars, whenever I show him these things, he says, Paul, did you command the apex? And I said, Drew, to the best of my ability, I commanded the apex. Now, if I command the apex, I also have to command the margin because the survivability, the success of this seal at the apex, well, part of that is how good a restoration I have to seal up that tooth against the ingress of bacteria in this area. It's just not underneath the skirt of my framework that I'm worried about. I'm worried about the survivability of this endo. So if I've gone through all that time and effort to get a good endo, I have to go through a lot of time and effort to get a proper fitting crown because that's what the patient deserves and that's what I am mandated to provide. So these little blebs here, would it have made a difference? I don't know, but I just know that a crown starts to fail the second you put it in. And my job is to make it fail as slowly as possible. Now, providing quality care, if you will, providing the best you can do, it's just not a moral or an ethical or a professional obligation. For those of you that are jaded out there, let's just put it in dollars and cents. From a dollars and cents point of view, it's good business to provide excellence. Because if you can demonstrate that, not just claim it on a web page, but if you can demonstrate it, then a patient will allow you to place crowns on the teeth that are needed without ever questioning you. And that's why developing trust, even when it comes down to assessing a defect in an impression, is important for sustainability in a dental practice over the long haul. Thank you very much.
Beautiful work as usual, Dr. Belzicki. Thank you.
You're welcome.